You're listening to Leverage.
To Leverage.
To Leverage.
An ASA Studios production.
Welcome to Leverage, ASA's podcast covering the politics of aging. I'm Amy Herr, ASA board member, co-chair of its Public Policy Committee, and Director of Health Policy at West Health. About a year ago, ASA and West Health released a special issue of Generations Journal on older adults and America's healthcare cost crisis. So much has changed since then, and the need to address healthcare costs has become more urgent than ever. Please join ASA and West Health as we talk healthcare policy and politics and get experts' ideas on the direction to take for better, more sustainable healthcare as we age.
Thanks, Amy. I'm Peter Caldas, CEO of the American Society on Aging and the host of Leverage. High healthcare costs, social isolation, loneliness, food insecurity, malnutrition, and issues related to housing have impacted older people for decades. But over the past year, the COVID-19 pandemic has made these issues even worse. In this episode of Leverage, we explore America's healthcare cost crisis and common sense ways we can lower costs and enhance care for all Americans as we age. We also cover the latest developments in California's statewide effort to build a master plan for aging, a 10-year blueprint that will help guide state government, local communities, private organizations, and philanthropies to build environments that promote healthy aging. California is among the first handful of states to build a plan in response to our aging society, following a process that can serve as a model for other states and the federal government. A little more than a year ago, ASA and West Health released a special issue of Generations Journal diving into America's healthcare cost crisis in the context of our aging society. Today on Leverage, I'm joined by Shelley Lyford, President and CEO of the Gary and Mary West Foundation, and Tim Lash, President of the West Health Policy Center. Welcome to Leverage, Shelley and Tim.
Great, thank you. We're happy to be here.
Great to see you, Peter.
So we're going to cover many issues today, but I wanted to start with a big one, and that is just how high healthcare costs have gotten. Tim, how do these costs impact older Americans, and really who else is affected by these rising costs?
Great question, Peter. We certainly spend entirely too much on healthcare. The numbers can be hard to wrap your head around. At a national level, we spend about $4 trillion on total healthcare expenses. If you look at things that many of us interact with on a daily basis, like prescription drugs, we spend over $400 billion. The problem is, that is unsustainable today. We see, seniors and just adults borrowing at a level that's unacceptable, $88 billion a year to cover healthcare expenses. But what's even more concerning is the trajectory. If you look at where healthcare costs are going, by 2040, we could spend upwards of $12 trillion on total national healthcare expenditures, which is not sustainable. When I think about seniors, it's a challenge for them in terms of the total spend, but part of it is that we're spending on the wrong areas, right? We know that medical interventions contribute to, maybe 15, 20% of healthcare outcomes. It's the investments in the broader supports around the senior that make, an even larger difference. The social supports, the network, the community-based organizations. And unfortunately, while we spend a lot in the United States, compared to other countries, we don't spend it necessarily in the right areas, and certainly not in the right areas for seniors.
Tim, let's get a little granular. What are some of the main drivers of these skyrocketing healthcare costs? What do we know also about how the pandemic has changed these costs?
Sure. So I'd say it's three things. First is how we pay for healthcare. The second is just the culture of medicine in the U.S. And then the third is the willingness to act to really drive meaningful change. On how we pay, we operate a fee-for-service healthcare payment system by and large in the United States, which means we pay for activity. Physicians make money, hospitals make money when we have medical interventions. And that doesn't necessarily promote, value-based care, or we're not paying for the outcomes that we're getting. We're paying for the activity, and that can drive profits very high. But what certainly happens is we have healthier profits, but ultimately, sicker, individuals, and certainly sicker seniors. And if you look at just as one metric, the life expectancy in the United States versus other developed countries, we're towards the bottom. Yet we spend much more. So we're paying for the wrong outcome. You don't pay for activity. You want to pay for the value, the clinical outcomes that you get. On the culture of medicine, there's a perception, one amongst providers, but I think more importantly amongst the consumers of healthcare, including seniors, that more is better, right? That in every case we should be, consuming more tests, doing more procedures. The bleeding edge of technology is going to be, sort of confer the best outcome. And it's simply not the case. Sometimes simple investments in nutrition and, just addressing social isolation and other things have, very material impact on the health outcomes that one can expect to achieve. And then finally, this willingness to act. We don't really have, the ability in the US to constrain price, right? We look at drugs. We don't negotiate the price of drugs. Medicare does not. There's limits on what even the private sector can do there. We see hospitals where they have significant share within a market service area, really just exploiting that sort of dominant market position to gouge employers and consumers of healthcare in a way that just contributes to that current $4 trillion spend.
And I would say, just to add, Peter, on this front, the pandemic has truly shined a light on the fragility of our healthcare system. So while that light is shining bright, I think we've also found a lot of opportunities where we can go in and we can create or leverage solutions that make a lot of sense, like telehealth. I think all of us in this country know the cost of isolation with respect to depression and loneliness. And loneliness has the same effect on your body as smoking 17 cigarettes a day. And if we can assure that we're keeping our seniors and our entire communities connected in a way that's meaningful, I think that's a huge opportunity. And that's something that we've at West Health and the foundation have really focused on throughout the pandemic.
That's so important to remind folks of how the pandemic has exacerbated social isolation and the healthcare, the side effects of it all. I want to go back to something you said, Tim, about trying to basically reverse the trend of these rising costs and a number of things that we should be doing. From a policy perspective, you wrote in Generations Journal that lowering drug costs, accelerating the adoption of value-based care, and increasing price transparency are three sort of obvious things we should be doing. Given where we are today, is that still possible? Do you think these reforms are still in play?
They have to be. The trajectory of the national healthcare spend, as I said, just isn't sustainable. And what's I think so elegant about the three opportunities, Peter, that you just highlighted, addressing drug spending, value-based care, and transparency, are that they're very timely in a COVID environment. So drug spending, why is it important? One, it hits people's pocketbooks every time they go to the pharmacy. The pharmaceutical sector is the most profitable sector within our economy. Even if you stripped $1 trillion worth of sales over a 10-year period out of it, it still would be the most profitable sector within our economy. So there's opportunity to lower the spend there and maintain R&D. We've done studies to prove that out at the same level. We can have the same innovation even with lower spend on drugs, and ultimately not be bankrupting individuals. And from a COVID, sort of policy opportunity, the savings associated with, controlling drug spend for Medicare could be used to pay for some of the other reliefs, for small business, for education, to name two areas that are going to be so important as we, try to steer this country out of the pandemic. As it relates to value-based care, I go back to, a point, comparing fee for service to, paying for the outcomes that we expect. What we found during COVID is that those organizations that were already under value-based constructs, ACOs and other risk-taking organizations, they fared much better with COVID because they had already proactively made the investments to be able to project care into the community. Shelley mentioned telehealth, a critical intervention during COVID. They've also embraced, sort of the broader supports that were necessary to address social isolation and other things. And I think the timing is appropriate. If we look at the historical major reforms in healthcare, so you had the prospective payment, which came in the 80s, and the Affordable Care Act, all of these were under the backdrop of the Medicare Trust Fund report, right? And what we'll see this spring is that the Medicare Trust Fund report will be released, and it will probably show, we anticipate that the trust fund will be insolvent in the year 2024, so just 3 years from now. And that, is going to provide a backdrop that really sort of motivates, right, Congress to look at opportunities like accelerating value-based payment structures to really address that. And then the third area mentioned is transparency. We at West view transparency less as a solution and more as a necessary condition, right? You can have fabulously transparent markets that are also fabulously expensive, but it's hard to imagine that we're going to get to a place where we're paying for the outcomes that are commensurate with the investment without first having, some visibility to what those prices are. And we're making some progress there. There was legislation that passed at the end of last year around surprise billing, major improvement, but there's more that can be done.
Tim, you mentioned timing, and it strikes me that federal policymakers often are slower than some of our state friends in our local communities. And so I know, Shelley, West Health has been an instrumental part of California's master plan for aging. Could you just share with our listeners who may not be in California what the plan is and how it came to be?
Yeah, thank you. So, Peter, as you know, California is the 5th biggest economy in the world. We also have 40 million people in our state, many of whom are over the age of 60. Every 8 seconds, somebody turns 65 in our country. And looking at our very big state, we quickly came to the conclusion that we need to have a plan in place to have better coordinated care for seniors and for families who want to age and live their whole lives in the state of California. So there's patchwork of services right now. Services do exist. However, it's very hard to find them, to reach them, to get them, to coordinate them. And a cohort of us came together and said, there has to be a better way forward. We've got to put a plan in place. So in 2018, the Gary and Mary West Foundation, along with the SCAN Foundation, based out of Long Beach, came together and created really this kind of action opportunity called We Stand with Seniors. And at the time, the gubernatorial candidates, Mr. Cox and Mr. Newsom, pledged with us that they would stand with seniors in our state. And they would create a platform in their respective administrations that were focused on seniors. And that came to reality. When Mr. Newsom became Governor Newsom, it truly was just a few, in his acceptance speech, he did say, I stand with seniors. And then a few months later, he created an executive order to create a master plan for aging. So it was really the advocacy efforts and the education efforts of these two foundations that came together and said, listen, we need to make this a priority in our state, the 5th biggest economy in the world. And since that time, when he created the executive order, he then created a stakeholder advisory committee, which had about 30 experts from across the state and various portfolios of expertise, of academia, from medicine, from housing, transportation, a whole host of different things that all of us need in order to successfully live in our communities. And we came together for about 12 months. And we created a master plan for aging. And it is truly a bold commitment to redefine aging in our state. It's a 10-year blueprint, and it is focused on state agencies with budgetary authority working together to implement over 130 initiatives in 5 areas. And the 5 areas include housing for all ages and stages, health reimagined, inclusion and equity, not isolation, caregiving that works, and then finally, affordable aging. So truly, this plan addresses aging holistically. And Tim and I always talk about this, and everyone at our foundation in West Health, aging is living. It's living. And so this whole idea of us kind of being afraid to talk about getting old or not wanting to address what it's like being old, it's like we're just kind of cutting our nose off to spite our face. And here, this plan shows the opportunities for the entire community to create a different way of living and a different culture moving forward, and embracing growing older. And so we're breaking down those barriers of ageism along the way as well. And I think the thing that's most exciting for West Health and all of those people who have worked so hard to create the master plan for aging is that it is not a document that is going to sit on a shelf and gather dust. We're very focused on implementation. And to that end, we have over 130 initiatives kind of within the bigger plan that are going to be implemented over the next 2 years. And West Health is going to help the state and all of the stakeholders kind of keep their feet on the fire by creating a host of data dashboards that focus and show in a very transparent way how we are doing with implementation. We're measuring our success, and we're going to focus on that. So very excited to be leading the country and implementing really a one-of-a-kind plan that we hope to transport across all states.
Shelley, just on that really important point, California is a nation state.
Yeah.
And scale does matter, and the opportunity to create and then deploy a master plan on aging in a state the size of California really does provide the evidence, right, and the learnings to allow other states that might not be as large, right, to take on similar activities, but also for the nation to learn from California and take steps for a more national master plan.
Absolutely. We're really excited about that opportunity. And we created this during this time of despair and during COVID. And who was the kind of suffered the most under COVID were our state seniors. And so we were able to really focus on those things, that what could we do better, like telehealth, like the creation of geriatric emergency departments, like better coordinated care, like nutrition, like addressing isolation, all of those things, which were really getting you could just have this light shining on all of those things during COVID. They just came to the surface in an even greater way. And our plan addresses those things.
I'm so glad that you mentioned that this is such an opportunity for other states to learn from California's, leadership, as well as your own foundation's leadership. I mean, it takes so many key players to drive a plan like this forward. I'm wondering if you could just share, your number 1 or number 2 tips for other leaders in other states that they should follow in trying to get their own plan going, right? What are maybe some pitfalls to avoid, or just I'm curious from your experience sort of in it.
All right, so I love that question because I think a lot of people from other states, let's just say from my home state of Vermont, will say, yeah, what are we going to, we live in a state filled with green mountains and snow and maple syrup, and we have 750,000 people. What are we really going to learn from California? California is such an incredibly diverse state. We have got areas that are rural, more rural than the New England states. And I think that what we have found is a huge opportunity where we can create public-private partnerships. And you can do that in any state and in any county. And in fact, that is what we, West Health and the Foundation, are doing with our county to roll out a new vaccine center. And I think that we'll talk about that in a few minutes, Peter. But with respect to other states replicating or learning from our blueprint, we have called this a blueprint. We've called our master plan a blueprint. We will send it out to every state, every county, every municipality in this country, because there are learnings and best practices that can be applied in every community. And there is the workbook and the steps to show how you move forward in creating a public-private partnership, how you can garner support from certain government agencies to roll programs out. And so that's what I think is so exciting about this. We've kind of, to an extent, we've created a bit of an easy button. And I think everyone loves an easy button.
And we will put up all of it on our website. ASA wants to be a part of disseminating these best practices. We think other states, like my home state of Florida, could learn from California's lead here. We know there are other pretty sophisticated states that are doing sort of their version of this. I suspect Colorado to a certain extent, Massachusetts to a certain extent. But I think about my birth state of Pennsylvania as well. These are all states that have huge populations of older adults that could benefit from this kind of strategic thinking, particularly with leaders like yourselves. I mean, I think this is just a fantastic model. I want to sort of tie this, though, to where we started, and that, Tim, is on healthcare costs. How do you think, whether it's the master plan for aging or generally, what other advocacy opportunities or policy developments do you think we could deploy or rely on that can improve healthcare costs?
Sure, Peter. So I think the timing is right because COVID has illuminated some of the fractures and flaws that exist and have long existed in our healthcare system in a new way. So there's new filters that we can look at just the current state of things. So let's peel them back. One is just what isn't working with our healthcare system. And there's a lot, right, in terms of the lack of coordination, fragmented care, payment for the activity. And that's something that's not new at all to seniors because on average, the older you are, the more healthcare you consume, and therefore the more experience you have navigating a fractured system. With COVID, even the younger, sort of consumers of healthcare have now experienced some of those fractures. So I think the timing is right in that there's just more awareness, right, and potentially more recognition of the need to change that system vis-a-vis where we may have been just, a few years ago. So that's the first lens, right? Just there's more people that know we got to do something. The second is COVID. When we went into COVID, there was a lot of debate as to what's going to happen with healthcare spending. Are we going to spend more? Are we going to spend less? Is it going to change? And I think if you look at the data in the aggregate at this point, we will have spent less, in 2020 versus 2019 on healthcare. And, that has some negative effects. There are people that did not access healthcare, for chronic conditions and other things that needed to because of some of the constraints that were put in place. But as Shelley mentioned, we've seen, sort of restrictions and regulations around, sort of telemedicine, been removed, right? And we found other ways to project care into the community at a much lower cost in a much more agile way. And, that's resulted in, people accessing the healthcare system in a new way, but, hopefully in a less expensive way. And certainly, we've seen, the rate of telemedicine hasn't, been sufficient to offset even in-person visits in terms of historically where we've been. So we're we're seeing savings around there, and we're certainly seeing savings around out-of-pocket expenses. So you have a proof point, right? That as a country, we were spending more, now we're spending less, and we're doing it because we're deploying healthcare in a different way. And I think that just you have to look at the scoreboard and say that is sort of evidence that things can be different. And then the third, I'd say, is just the agility that community-based organizations and healthcare providers have demonstrated, during the pandemic. There's a real opportunity to reflect on, sort of what has worked and what hasn't worked, and use that to inform some, sort of durable, change to, how we pay for healthcare and how healthcare is accessed. And you mentioned, Shelley, the vaccine clinic. We operate a PACE program for all-inclusive care for the elderly here in San Diego, which really deals with the most frail seniors, in a community, those that would otherwise be in an institutional setting. And we were very proactive within that program to ensure that we would have access to the vaccine and the infrastructure to be able to, start to bring our population out of this pandemic. But what we quickly realized is that, seniors have been, affected disproportionately hard, by COVID. And they're also struggling at a disproportionate level, navigating their way out of this pandemic, which is getting sort of vaccination. And why is that? Because, there's a technology divide. Many people don't have the ability to sort of access, sort of the internet or some of these scheduling softwares. They don't have someone to help them just sort of navigate, even where to go, because it's very fractured. And what we decided to do was partner with the County of San Diego and the local 211 system, which is a call-in line that can provide some of these supports, to provide a much more streamlined process for seniors in San Diego to access the vaccine.
So we are breaking down the technology barrier and the transportation barrier, and we're able to provide much needed life-saving services to the most fragile in our communities. So it's exciting work. And again, this also shines a light on the opportunities that we have with creating public-private partnerships. We're doing this with an amazing community-based organization, 211, who knows our community, who knows the needs, who knows the services that we have access to and that we don't have access to, where the gaps are, and the county.
I love to hear that. And I think if I may add another word to your list of why this is so groundbreaking, it's also about leadership, Shelley and Tim. It's leadership in what West Health is doing. We've highlighted how you're involved in leading on solving for systemic issues at the national level. You're leading in part of a multi-stakeholder process at the state level, and you're leading on COVID vaccinations at the local level. And I think, to me, the common denominator there is your leadership. So thank you for your leadership on these issues on all these fronts. So I'm just extremely grateful for the work you're doing in California, for your partnership with ASA, and just for the impact you're having nationally. So Shelley, Tim, thank you so much for joining me today on Leverage.
Thank you, Peter.
Thanks, Peter.
Thank you.
And to all our listeners, don't forget to subscribe to Leverage, the podcast on the politics of aging, wherever you get your podcasts.